Hi, my name is Megan Lyon, and I am thrilled to introduce you to today's webinar, which is Introduction to Cystic Fibrosis and Sickle Cell Disease Newborn Screening. So we have a wonderful speaker today that will be talking about Public Health Genetics and Genomics Week, providing an overview of newborn screening, and then talking specifically about cystic fibrosis and sickle cell disease and newborn screening. As I just mentioned, this is our webinar outline. We're very excited to be doing this webinar in collaboration with Public Health Genetics and Genomics Week. And so we'll be talking about the week, giving you a bit of an overview of who we are, then the newborn screening as a public health program, cystic fibrosis and sickle cell, and then a question and answer period. I know that the question and answer seems like it is at the bottom, but please feel free to chat your questions throughout the webinar so that we can answer them. So as I said, my name is Megan Lyon. I am the co-project director of the National Coordinating Center for the Regional Genetics Networks, otherwise known as NCC. It is a very long name. And we are the ones who host Public Health Genetics and Genomics Week each year. Before I get into PHGW, I wanted to give you a brief overview of NCC and the regionalized system in case you hadn't heard of us before. So we are funded by the federal government. We're funded by the Health Resources and Services Administration, or otherwise known as HRSA, along with the 7 regional genetics networks and the National Genetics Education and Family Support Center, otherwise known as the Family Center. As you can see from our map, every state is covered by a region, as well as the DC, Guam, Puerto Rico, and the U.S. Virgin Islands are a part of our regional system. So all 7 regions, NCC and the Family Center, work collaboratively towards our common mission of improving access to genetic services for underserved populations. And the way we do this is through a public health approach. And so there are a couple of core pillars that are part of the regionalized system and the national system, which include genetics and genomics education. So at the regional and national level, we provide tools, resources, webinars such as today, to educate providers, both genetic and non-genetic providers, individuals who are at risk for or have genetic conditions, as well as their families, or just individuals who's interested in genetics so that they can learn more about a specific condition, or it might be a conversation around systemic issues and barriers and how we can alleviate those through education related to genetics and genomics education. Another core pillar of the system is telegenetics, or telemedicine services for genetics providers and genetics patients. So the regionalized, all the regions offer training programs, educational support, some financial support, technical assistance, things like that to providers and families so that they can get access to telegenetics, or they can provide telegenetics to their patients. In addition to those efforts, as we are funded by the federal government, we do collect data at the regional and national level to understand if we're achieving our mission of improving access to genetic services for underserved populations. So NCC is tasked with collecting data from the regions, as well as ourselves and the Family Center, to understand what our impact is. And you can go onto our website and see who we're helping in example programs of how we're achieving that mission. And then finally, NCC is tasked with understanding the policy landscape throughout the country. So we are tasked with understanding what's happening at the state and federal level related to legislation and regulation. We track policies and Medicaid programs. So we look at a Medicaid program websites every year to understand what they're covering or they're not covering related to genetic testing, counseling, and follow-up services. We also then have an area where we talk about why a policy area is a policy concern in genetics and share policy statements from national organizations. In addition to that, we run webinars and other educational events to help people understand more about genetics policy, one of which is tomorrow, where we'll be talking about genetics privacy through our Genetics Policy Hub webinar series. And so all of that, I hope, gives you a sense of that our work really is rooted in public health and taking public health approaches to understand and to mitigate barriers and the delivery of genetics. And so a number of years ago, NCC really started to go to more public health meetings. We've gone to genetics meetings for years, but really started to see that there wasn't necessarily a ton of education or understanding necessarily within the public health field about the role of genetics, or in the genetics field about the role of public health, except in certain situations. And so due to that, we started to host Public Health Genetics and Genomics Week in 2020. I will stop here and say that while NCC is the one who hosts the week and we develop materials and things like that, it is completely a collaborative effort in order to host this week. And we bring together the regions, state health departments, federal agencies, advocacy organizations, nonprofits, all who work within the space of public health, genetics, and genomics, so that we can all bring together everybody who's in the field or who's interested in the field to raise awareness about public health, genetics, and genomics, and to celebrate it. And so the question we often get when discussing the week is, what is public health, genetics, and genomics? And I will say that there are varying definitions. Like this is a definition our group came up with when we were conceiving the week, but there are definitely different ways of thinking about it. And that's why we hold these events, is we want to have conversations about how people frame public health, genetics, and genomics, and what programs they think about. And newborn screening is an exemplary public health, genetics, and genomics program. And so we define public health, genetics, and genomics as applying genetic and genomic information to improve public health and prevent disease. This definition, while we're happy to have a definition, is not necessarily the most accessible definition for an audience who may not be familiar with public health, who may not be familiar with genetics. And so the week is structured to be an educational week, and it is structured around daily themes to help people understand and to learn about what public health, genetics, and genomics is. So every day of the week has its own theme. Along with that theme, we have web pages, fact sheets in English, Portuguese, and Spanish, social media graphics, other things to help people understand what it is. So we start the week with what is public health, genetics, and genomics. Then we talk about who's involved in public health, genetics, and genomics. Yesterday, we highlighted programs that are that exemplify public health, genetics, and genomics. Today's Public Health Screening Day, so we talk about population screening, non-invasive prenatal screening, but definitely newborn screening is the big one, and that's why we're very excited to have our speakers together today to talk about newborn screening for specific conditions. And then tomorrow will be Public Health, Genetics, and Genomics resources, where anyone who works in the system or even dabbles in the system, but has resources to share, everyone can share their resources. And so this graphic is on our website, and we'll put a link in the chat about how to get to this website, but you can go in and explore the daily themes. For events that have already occurred, we'll put up recordings when they are available, as well as other activities to help celebrate the week. And so with that, I'm very excited to hand it off to Dr. Marcy Sontag to give an overview about what newborn screening is. And so Dr. Sontag is an epidemiologist and the director of the Center for Public Health Innovation at CI International, Littleton, Colorado. She is currently working to identify solutions to improve newborn screening for cystic fibrosis in partnership with state newborn screening programs and CF centers. And she directs the Colorado Sickle Cell Data Collection Program, which is funded by the CDC. And with that, I'll turn it over to Dr. Sontag. Thank you so much.
Welcome. Thank you so much, Megan. Next slide, please. Newborn screening is undoubtedly one of the biggest successes in public health genetics and has been touted as one of the successes overall as a public health program, touching more than 3.8 million babies each year in the United States. The disorders screened for under newborn screening are rare, and newborns typically show no symptoms within the first days or weeks of life after birth. Early identification of these newborns can prevent death or disability in the newborns. And we really look towards the newborn screening systems to optimize outcomes for all infants throughout the United States with all of these conditions. Next slide, please. Screening is initiated at the birthing facility, typically within the first 24 and 48 hours of life. And the birthing facility here is depicted as a hospital. However, that may be a birthing center or a home birth, as every infant should be offered newborn screening. Two disorders, early hearing loss and critical congenital heart disease, are screens that happen at the hospital and those or at the birthing facility. And those are considered point of care tests, where the entire test is encapsulated in that birthing facility. Today, we'll be focusing on disorders that are tested through a dried blood spot collection on filter paper. So what typically happens is that within 24 or to 48 hours after birth, is a small amount of blood is collected on a filter paper and sent via a courier service, ideally, to the state public health lab. Now, that courier service is critical in getting that specimen there early, really in partnership with the very timely collection of that specimen at the hospital. Once it's received at the public health lab, the specimen is processed and then tested by a team of laboratory specialists who are testing for dozens of disorders, again, doing that in a very timely fashion, and then calling out disorders that with abnormal results to pediatricians and to clinical care specialists for diagnostic confirmatory testing. There is a team of follow-up specialists who will ensure that that baby gets the appropriate testing and follow-up to either confirm the diagnosis or to rule it out. And this system of folks really works tirelessly in order to ensure that babies are healthy and have that best opportunity for a long, healthy life. Next slide. Currently, there are 37 disorders on the Recommended Uniform Screening Panel, or RUSP. The Secretary of Health and Human Services has an advisory committee called the Advisory Committee on Heritable Disorders in Newborns and Children, and they're the ones who make the recommendations for these disorders. Disorders are on this panel because they have reliable testing that can be done on a wide basis at newborn screening public health laboratories throughout the country, coupled with the opportunity for early therapy and treatment for these disorders that can really alter the course of the disorder and the course of life for those individuals. Two of the more commonly identified disorders among those 37 are cystic fibrosis and sickle cell disease. These two disorders have been screened in at least some of our states in our country for more than 40 years, and we have now identified thousands of infants who have benefited from early diagnosis through newborn screening for both cystic fibrosis and sickle cell disease. And we will hear more about both of these programs later in today's webinar. Next slide, please. So in summary, and in celebration of Public Health Genetics and Genomics Week, we really can say that newborn screening is one of the greatest public health successes, and I would say arguably the greatest public health genetics success to date, where thousands of infants are identified and offered early treatment each year. Through the partnerships through public health laboratories, public health follow-up programs, and clinical specialists and pediatricians, we now have earlier collection, faster transport, and more efficient systems that really lead to a more timely referral and treatment, which benefits infants with these disorders. However, there are still opportunities for improvement. We know that disparities may still exist. Those disparities may include disparities really directly stemming from how we do some of the testing. There may be disparities related to access to care and understanding the therapies and treatments that are out there. And so this provides opportunities for improvement to achieve equity for all infants. And both the cystic fibrosis community and the sickle cell community are working hard to improve equity for all infants to ensure that all children have the best possible outcomes with both of these disorders. So with that, next slide, I am proud to be able to introduce Dr. Stacy Martiniano. Dr. Martiniano is an associate professor of pediatrics at the University of Colorado and Children's Hospital Colorado. She's a pediatric pulmonologist who cares for infants and children with CF, and she's involved with several national research studies and quality improvement projects working to improve the timeliness and equity of newborn screening in the US. Stacey, hand it to you.
Thank you, Marcy. And thank you again to the organizers and to you all for being here and for your interest. I'd like to start by pointing out that May is Cystic Fibrosis Awareness Month, so I'm especially happy to be here presenting to you all about CF newborn screen. Next slide. So I'd like to start with some basics about cystic fibrosis. So CF is a multi-system progressive genetic disease that is characterized by chronic pulmonary infections, malabsorption, and nutritional abnormalities. And we estimate there are currently about 40,000 children and adults with cystic fibrosis in the United States. CF is caused by variants in the cystic fibrosis transmembrane conductance regulator, or CFTR gene. And specific information about these individual disease-causing CFTR variants can be found at cftr2.org for anyone interested. And this is a phenomenal website that was actually recently updated in April. So abnormalities or absence of the CFTR protein impacts the way in which salt, bicarbonate, and water move in and out of cells, especially in the lungs, the digestive system, and the sweat glands. So therefore, without treatment, disease can start early, and infants can present with severe malnutrition, electrolyte disturbances, and heat prostration or overheating. Now, we have been so fortunate in the CF community to have significant advances in treatment options for CF, especially in the last decade. However, despite these advances, CF remains a life-shortening chronic disease. So therefore, early diagnosis and treatment initiation are still critical, especially as hopefully these new disease-modifying medications actually become available for our infants in these next coming years. Next slide. So cystic fibrosis newborn screening became universally offered in all 50 states by 2010. And generally speaking, CF newborn screening is a two-step process. It starts with either one or two measurements of immunoreactive trypsinogen, or IRT, from the dried blood spot. And IRT is a biomarker of pancreatic damage. If the IRT is elevated, then a DNA analysis for CFTR variants is performed. Now, there is a lot of variability between states. And I also want to emphasize that newborn screen is not diagnostic. It is really meant to be a risk assessment, and still diagnosis must be confirmed through sweat testing at an accredited lab. Next slide. But I'd like to touch a little bit more about touch more on the state-to-state variability that occurs in CF newborn screen. So some of the variations, some states perform one screen for IRT elevation prior to testing cfDNA, while other states perform two screens. In the two screen states, if that first IRT is elevated, a second blood spot is collected and tested for IRT again at 10 to 14 days of age. If the IRT is again elevated in these two screen states, then the DNA test is done on that second sample. Additionally, some states used a fixed cutoff for their IRT values, while other states use a floating IRT cutoff. Floating IRT cutoff has advantages. It can better account for seasonal variation and test variability that can occur with IRT, and therefore has lower false negative rates. Lastly, states use a variety of CFTR variant panels for DNA testing. So here are two figures from a paper by Drs. Rahani, Farrell, Wren, et al. And just to help you visualize some of the state-to-state variability. On the left map, you can see different shading to represent the different IRT cutoff values that are used among the different states. And then on the right map, you can see different shading to represent the different number of CFTR variants tested on state panels. And the numbers range from either one CFTR variant number or variant tested to greater than 139 variants tested. So since every single state has a different process for newborn screening for CF, the likelihood of correctly receiving a positive newborn screen for babies with CF depends on where they're born. Next slide. So I'd like to shift and talk about the benefits of diagnosis through newborn screening. So newborn screening leads to earlier diagnosis and improved health, as Marcy mentioned. In a study by Dr. Margaret Rosenfeld and colleagues, they compared health outcomes of infants diagnosed in this more recent post-newborn screen era and compared them to those diagnosed with CF prior to the availability of newborn screen in their state. Advance. And what they found was that infants diagnosed in this post-newborn screen area, shown in both figures in orange, these babies had improved weight for age, starting at their first visit and lasting through their follow-up period of 9 years of age. And this is shown in that left panel. Post-newborn screen babies also had improved lung function through 10 years of age. And they also had reduction in hospitalizations. And that's some data we've seen in our own work. Next slide. So despite universal newborn screen and all these health benefits, we still do see that complications persist. So our newborn screen study group reported that among infants diagnosed through newborn screening, nutritional deficits were still common at the initial CF encounter when they received their care. So for example, about 40% of babies had a weight for age less than the 10th percentile at that first visit. About 4% reported having steatorrhea, which is a sign of malabsorption, and 5 to 6% reported having true failure to thrive or signs of malnutrition. We also saw that hospitalizations were pretty frequent within the first 3 years of life. So about 35% of infants had at least one hospitalization in that first year of life, and about 30% had a hospital stay between 1 to 3 years of age, which all are signs that certainly disease is still occurring. Next slide. Next slide. So we have evidence that these complications are at least in part due to the fact that not all infants with abnormal newborn screens are receiving prompt referral and care initiation. So our goal is that all babies are diagnosed and have care started before 30 days of age. One way that we can try to evaluate this further is through using a process measure called Age at First Event, or AFE. And this is a date that we can extract from our National CF Patient Registry database. And it is the date of one or more of the following, the earliest date of one or more of the following: their sweat test, a clinical visit encounter, or a hospital stay. So this AFE, we feel, is this clinically meaningful date, an estimated age when a baby actually first receives care and has their CF treatments started. So advance. So looking at data from the National CF Patient Registry sponsored by the CF Foundation, we found that since universal newborn screening began in 2010, 65% of babies with CF in the registry had an age of first event, meaning care initiation, less than 30 days of age. And this is wonderful. Of course, though, this means that there are still babies being diagnosed greater than 30 days of age. And in fact, 1 out of 8, or 12%, were evaluated even after 2 months of age. Next slide. So we really feel that not only is CF diagnosis through newborn screen important, but prompt referral and timeliness in CF diagnosis and care initiation is really key. And so we've seen also further that early evaluation is associated with even better early life nutrition advance. So among the group of infants diagnosed through newborn screen, we compared infants born late compared to those who were diagnosed early. And we did this through dividing infants into quartiles and matching for race, ethnicity, gender, several variables that can affect socioeconomic status and also nutritional status. And so what we saw that late babies who had an average of 47 days of care initiation compared to early babies who had an average age of 10 days of life for care initiation. These late babies had, please advance. The late babies had lower weight at that first evaluation, but had persistent lower weight compared to the early babies at their 1-year-old encounter. The late babies also had lower height at their first evaluation, and this difference in height compared to the early babies persisted through age 5 years of age. And we feel these are very clinically important and meaningful findings since early life weight and height are associated with improved pulmonary function and survival in later life. Late babies also had reduced breastfeeding rates at ages 2 and 6 months. And then another interesting finding we found were that late infants had less frequent rates of 2 CFTR variants detected on the common newborn screen panels. And this likely contributed to their later diagnosis. Next slide. We also see disparities exist in time to first evaluation, specifically related to race and ethnicity. Dr. Susanna McCauley and colleagues reported that minoritized infants with CF who identified as Black or African American, American Indian or Native Alaskan, Asian, another race or Hispanic ethnicity had later age at first event than white and not Hispanic infants. And the difference was 31 days versus 22 age advance. Additionally, resultant differences in weight at 1 year of age were seen between these groups. Thank you. So also, we think that some of this racial and ethnic disparities in diagnosis may be related to restrictive newborn screen cfDNA panels that I mentioned earlier. So this figure was adapted from work published by Dr. McGarry and colleagues and shows the average detection rate of 1 or more CFTR variants across common variant panels that are used in our states. And it's divided by race and ethnicity. So you can see that Asian babies and African American and Black babies are less likely to have variants detected on the common newborn screen panels. Advance. And overall, across the United States, we estimate that about 11% of people with CF have experienced delayed diagnosis or have had a false negative newborn screen. But among non-white populations, as seen by the data on the left, Black or African American babies and Asian babies experience the highest rate of false negative newborn screen or delayed diagnosis. Next slide. To wrap up, I would like to highlight some of the Cystic Fibrosis Foundation priorities and work that is being done to begin to address this equity and timing issues related to CF newborn screen. And to really achieve equity in newborn screen, it is felt that nationwide best practices are needed with attention made to these 3 key elements. 1, employing the best IRT cutoff value tactic, and when possible, transitioning to floating cutoffs. Number 2, to offer expanded and non-discriminatory CFTR panels that include pathogenic variants that are found in racial minorities. And number 3, to really ensure more expedited follow-up systems to diagnose all CF infants during the neonatal period, ideally by 2 to 4 weeks. Next slide. So the CF Foundation put together this newborn screen steering committee, and it consists of patients with newborn screen experience, genetic counselors, CF clinicians and researchers, CF Foundation and staff, newborn screen state lab directors, a bioethicist, and pediatricians. And this steering committee has been charged to develop a CF newborn screen consensus guideline that really addresses these key elements and additional gaps in equity. Next slide. So in summary, I'll leave you with these key takeaways. Advance. So timely evaluation and treatment improve health outcomes for people with CF, and prompt referrals for infants with an out-of-range newborn screen result are key. Next. That we'd like you to be aware that false negative newborn screen results occur, and there are limitations of our current genetic-based testing. Advance. And there's a national CF newborn screen initiative with our goal to improve equity, sensitivity, and timeliness in diagnosing babies with CF. And this is going to be achieved ideally through state quality improvement initiatives, partnerships with you all, and dissemination of these data to achieve nationwide best practices, improved health outcomes. Thank you.
Thank you so much, Stacy. That was perfect. Wonderful presentation. And before we move on to Dr. Tang, I'd like to highlight some of the slides that Stacy presented came from or were extracted from an infographic that has been developed through funding from the CDC. And Dr. Susanna McCauley is going to send a brief message on if you'd like to get more of that infographic. It's brand new and hot off the presses. So we're very excited to be able to share that with you if you are interested in sharing that with your communities. And with that, I'd like to introduce Dr. Amy Tang, who will be talking to us about newborn screening for sickle cell. Dr. Tang is an assistant professor of pediatrics at Emory University and Children's Healthcare of Atlanta. She is a pediatric hematologist who cares for children with sickle cell disease and other blood disorders. She is the co-director of the newborn screening follow-up program at Children's Healthcare of Atlanta and is involved with the Georgia Sickle Cell Data Collection Program funded by the CDC to collect information on diagnosis, treatment, and access to care for individuals with sickle cell disease. Dr. Tang, welcome.
Hey, thank you for having me today, and thanks for the organizers and to everybody who's in attendance. So I'm going to be talking to you guys today about newborn screening for sickle cell disease. And this is an area that's very near and dear to my heart. So I appreciate the opportunity to share more information about this disease. Next slide, please. I'm going to start off with just kind of the basics of sickle cell disease, since I realize there's a mixed group here. Sickle cell disease is a problem with the hemoglobin inside of the red blood cells. So hemoglobin is composed of 2 alpha globin chains and 2 beta globin chains. Next. And within each of your red blood cells, you have about 250 million hemoglobin molecules. And so sickle cell disease comes about when there's a mutation in the beta globin part of your hemoglobin molecule. Next slide, please. So in the beta globin in sickle cell disease, you have a mutation in one of the amino acids, which causes the normal hemoglobin A to be a hemoglobin S, or sickle hemoglobin instead. And there's a lot of genetic heterogeneity in different types of sickle cell disease. The most common type is where you have 2 sickle mutations in your beta globin gene. So this is the SS type of sickle cell disease. But there are a number of others as well with varying severity. So this includes hemoglobin SC disease, hemoglobin S beta thalassemia, and others. The overall pathophysiology in a simplified version is that the hemoglobin S molecule causes dehydration under deoxygenated conditions of the red blood cell. So the red blood cell turns into the sickle conformation that leads to occlusion of the vasculature and also chronic hemolysis, which leads to most of the downstream effects that we see with sickle cell disease. Next slide, please. And so there are some inherent differences in red blood cells between people who do and don't have sickle cell disease. A normal red blood cell is disc-shaped and deformable and has a lifespan of about 120 days, whereas sickle red blood cells have this characteristic sickle formation, and they're a lot more rigid and only live for about 20 days or less. So our patients have chronic anemia due to the shortened lifespan of their red blood cells. Next, please. And this is a map looking at the global distribution of sickle cell disease. So within the United States, we estimate that there are probably about 100,000 individuals living with sickle cell disease. And this translates to about 3,000 births a year, or about 1 in 365 people who are of Black or African American descent. Worldwide, however, it's a much bigger issue. So there are actually millions of people in the world who have sickle cell disease, and about 300,000 births a year. Most of these are actually in sub-Saharan Africa, where unfortunately there is not universal newborn screening. And so most of the disease burden lies in areas where people are really ill-equipped to diagnose the disease early on. Next. In the United States, these are some population estimates by state. So I live in Georgia, which is one of the higher prevalent areas in the country, but you can see most of the sickle cell disease in the country is along the East Coast, the South, and in California. So the history of newborn screening for sickle cell disease is shown here. If we think about back in the 1970s, the overall survival for sickle cell disease was only about 14 years. But since then, there have been a lot of advances in diagnosis and screening and treatments for the disease. So this started off with targeted population screening in the 1960s, followed by in the 1970s, there started to be a lot more attention to issues of equity, and this included issues of sickle cell disease diagnosis. So we start seeing a lot more screening programs for sickle cell disease, including in 1975, the first state newborn screening program for sickle cell disease was established in New York. This was followed by several additional studies looking at best practices for sickle cell disease, including an important one in 1986, which recommended prophylactic penicillin for all infants and children with sickle cell disease. And then universal screening for sickle cell disease was finally adopted by all states in 2006, so not that long ago. By 2010s, the overall survival for sickle cell disease had improved to 54 years of age. So still not normal, but better than 14. Next. You can advance to the next. So these are the common types of results that we'll see on newborn screening in somebody who has sickle cell disease. A normal newborn screen is FA, and these report basically the different types of hemoglobin that the baby has. And this is taken from the dried blood spot from the newborn screen. So F is for fetal. All babies are born with mostly fetal hemoglobin, and the hemoglobins are reported in order of decreasing prevalence. So a normal newborn screen would be fetal hemoglobin followed by hemoglobin A. A is for normal adult hemoglobin. Somebody who has sickle cell trait would have an FAS pattern on their newborn screen. So they would have more fetal than adult and more adult than sickle hemoglobin. Versus somebody who has FSA on their newborn screen, that would mean that they have what we call S beta plus thalassemia, which is a type of sickle cell disease where you are still making a small amount of normal hemoglobin A. FS is typical of the most common type of sickle cell disease, which is the SS type of sickle cell disease, or it can also be S beta 0 thalassemia, which is another type of sickle cell disease where you're not making any normal hemoglobin. The other thing that FS could be is something called SHPFH, which stands for the hereditary persistence of fetal hemoglobin. And this is clinically a lot more benign than sickle cell disease because although you're not making any normal adult hemoglobin, you still are making sufficient fetal hemoglobins to mitigate the anemia symptoms from the hemoglobin S. And then lastly, FSC is another type of sickle cell disease called SC disease, where you're making hemoglobin S on one chromosome and hemoglobin. So these are the different laboratory methods that are used for newborn screening, and generally most states will start with one method as their initial test and then do another method as a confirmatory test. So the three methods are isoelectric focusing or gel electrophoresis, where the different hemoglobins are separated on a gel by electric charge. There's also HPLC, which is high performance liquid chromatography. And then there's capillary electrophoresis, where the hemoglobins are separated in a capillary. So when you see any of these on the newborn screen, FS, FSA, FSC, or FSV, which is for variants, these are all indicative of likely sickle cell disease. So these patients will need to be referred to a hematology provider where they will have a repeat electrophoresis done at the first hematology visit to confirm their newborn screen result. And if the newborn screen was fetal sickle, remember there are a couple of different genetic diagnoses that could be. So we'll need to repeat the electrophoresis when the baby is older at around 9 to 12 months of age, once the fetal hemoglobin has gone down, in order to confirm their exact sickle cell type. And so the way this is done in Georgia is that we have 2 newborn screening follow-up coordinators that are responsible for all the babies in the state who have a diagnosis of sickle cell disease on the newborn screen. And they are in charge of contacting the pediatrician and the family to make sure that the babies are established appropriately in fertility. And so the importance of getting newborn screening is that there are a number of early interventions that we can perform for sickle cell disease that have been shown to improve the overall outcome. One of the most important ones is penicillin prophylaxis starting at diagnosis. So as soon as we get that positive newborn screen result, we will ask that the pediatrician go ahead and start penicillin prophylaxis for our patients. And I'll go into a little bit of the data on that. Additionally, we recommend additional coverage for pneumococcal and meningococcal vaccines. We teach our parents how to do palpation of the spleen to identify splenic sequestration, which is a complication that can be potentially life-threatening in our young patients. And then we also perform transcranial Doppler or ultrasound screening starting at age 2 to screen for individuals who may be at increased risk of stroke. And if this screening is abnormal, we start these patients on chronic red blood cell transfusions as stroke prevention. We also recommend a medication called hydroxyurea for all patients who have the more severe types of sickle cell disease or sickle cell anemia. And those are the SS or S beta 0 genotypes. And this starts around age 1. So this study was back in the 1980s, before we had started a lot of our current screening tools and prophylaxis measures for sickle cell disease. And this looked at 73 children and adolescents who had died, who also had sickle cell disease, and looked at basically the causes of mortality. And you can see the number 1 cause of sickle cell related mortality was actually bacterial infection. This is because individuals who have sickle cell disease have functional asplenia, where they have increased susceptibility to certain bacterial organisms, especially encapsulated organisms. The second most common cause of mortality was stroke, followed by acute chest syndrome, splenic sequestration, and aplastic. This was the study that led to us starting penicillin prophylaxis in all of our children with sickle cell disease. So like I mentioned, people who have sickle cell anemia are more susceptible to certain bacterial infections. And so in order to prevent these infections, the study randomized patients to either getting prophylactic penicillin or a placebo. And in 15-month follow-up in the placebo group, there were 13 infections and 3 deaths, whereas in the treatment group, there were only 2 infections and 4 deaths. So this was actually an 84% decrease incident rate of infection with penicillin. So now we start penicillin on all our children with sickle cell disease or sickle cell anemia, at least up until age 5. Next. And so this is one of the reasons that there is a strong imperative for newborn screening, is because, you know, knowing the newborn screen results, we can start the penicillin earlier in our patients and hopefully prevent some of the infection. So in 1987, the NIH consensus panel started recommending universal newborn screening for sickle cell disease. Next. The other major thing that we've done in the past few decades is to start doing transcranial Doppler ultrasounds to look at stroke risk. So this is a non-invasive method of measuring blood flow in the large intracranial vessels. And if you have increased flow, then that is indicative of potential stenosis inside one of the vessels. Next slide. And this looks at the outcomes of starting to do these transcranial Dopplers. So in California implemented newborn screening for sickle cell disease in 1990. It was one of the earlier states. And then we had a pivotal study called the STOP trial that was published in 1998, the outcomes of which caused us to recommend TCD screening for all patients with sickle cell anemia. So after we started doing this, you can see that the incidence rates of first-time stroke decreased dramatically in patients with sickle cell anemia. Next. And our overall survival has also improved dramatically from the 1970s. So these are different cohorts of patients over time and in different locations. In Jamaica in the 1970s, the overall survival was only about 75% to adulthood, whereas in more modern times, the survival is approaching 95%. And this is due mostly to the use of universal screening along with prophylactic penicillin, immunizations, splenic palpations, and other treatments that were currently. Next. So there are a couple of limitations to newborn screen. It may be inaccurate if the baby was transfused prior to the newborn screening being done, or if the baby has extreme prematurity, or if the hemoglobin on the dried blood spot has degraded. And then I did want to mention really quickly about sickle cell trait, which is reported on the newborn screen, but the follow-up varies by state. So some states will report it directly to the family, or some states will report it to the pediatrician, but most of these patients are not followed by a hematologist. However, there are increased risks of certain things like thrombosis, renal medullary carcinoma, chronic kidney disease, and something called exertional collapse related to sickle cell trait, which is an issue in student athletes performing at high levels. And so the NCAA actually mandates sickle cell trait testing in all student athletes now, although, you know, theoretically, if they were born in the United States, they should have these results based on their newborn screen. So after the newborn screen is completed, the short-term follow-up is to make sure that the results are reported to the pediatrician as well as to the hematologist for follow-up, to start the infant on penicillin prophylaxis and do confirmatory testing at the hematologist's office and to establish appropriate. Long-term follow-up, however, is a little bit more complicated and doesn't really stop at infancy. So one of the goals, overall goals for sickle cell disease surveillance is to ensure that we allow our patients access to treatment and preventative care throughout their lifespan, not just up until their first. We also are working on better ways of measuring health surveillance population-wide and looking at outcome measures and healthcare utilization in these patients. And ultimately, our goal is to use the newborn screen results to help to track these patients and hopefully to successfully transition them to adult oncology. Next. So that is the end of my slide, and I think we have a question and answer session.
Thank you, Dr. Tang and Dr. Martiniano. And we'd like to open it up for questions for any one of our speakers. Please feel free to chat your question into the chat box or take yourself off mute and turn your video on and join us in the conversation. The last question, Shamara Pope from the CDC just asked at what point after birth are premature babies screened for sickle cell. I answered that as all babies are recommended to be screened for 24 to 48 hours. And I didn't have time to do a follow-on to that, is there's also specific CLSI recommendations on NICU babies and repeating those specimens again if they get transferred from a local hospital to a NICU, when to do that, et cetera. And so I can also share those recommendations with you, Shamara, offline.
I'll also add that for our babies where the newborn screen is and it ends up getting sent after the baby's already been transfused, we do have the capability to do genetic testing for confirmation of their diagnosis.
Oh, perfect. And Amy, do you know, do all states have that capability, or is that something that's unique to Georgia, or not necessarily unique to Georgia, but is that something that you do that maybe not everyone?
I believe it's most states, but I'm not sure exactly how many states have that capability. But some states actually use genetic testing as one of their initial.
And Amy, this question is also for you. Are electrophoresis results more valid at 9 to 12 months of age since the blood has had more time to mature?
Yeah, that's a good question. So the main reason that we do the repeat electrophoresis when the baby is older is because the fetal hemoglobin has had time to go down. So at birth, the fetal hemoglobin is around 90–95%. And so you can imagine your remaining hemoglobin are in much smaller percentages. So by 9 to 12 months of age, the fetal hemoglobin has gone down to probably about 20 to 30%, which makes it easier to figure out what the other hemoglobins are that are present. So that helps with the diagnosis.
Perfect, thank you. That's very helpful. Stacy, the next question is for you. Are you aware of evidence or correlation of any CFTR variants that may escape or borderline IRT cutoffs, escape or have borderline IRT cutoffs?
I apologize. I don't know if there are data surrounding that. To me, I am not aware about specific gene variants. I would like to make a comment though about meconium ileus. So this is in utero bowel obstruction that can occur in some patients with cystic fibrosis who have pancreatic insufficiency. And we can see falsely low levels of IRT in babies that are born with meconium ileus. I kind of think of it that the pancreas is already burned out, so that biomarker is no longer being released in the blood at birth. So we encourage nurseries, if there is presence of meconium ileus, to be aware that that could falsely lower IRT, and that either genetics are directly done on those samples, even with a low IRT, or a later testing with sweat test or other genetics is performed.
Perfect, thank you, Stacy. And adding on to the question about the CFTR variants and IRTs, it's interesting because I think there's some cases where kids with very common variants that are typically related to pancreatic damage early on might have low IRTs. So it is definitely very much variable with that. So having a lower IRT preferably with a floating cutoff, I think is what the current recommendations are leaning towards to ensure that everyone goes on to CFTR variant testing. There's a question that is a follow-up about the electrophoresis. So it's back to you, Amy. The question is, you still want to do an electrophoresis after the first newborn screening result. Does this mean all babies that flagged for possible disease are started on penicillin?
Yes, that's correct. So as soon as we get that newborn screen result, we tell the pediatrician to go ahead and start the penicillin because we don't want to wait on the confirmatory testing since the infant is already at risk for infection in that early period.
The next question is related really for both of you. Chris Harden says, many school systems are unaware of sickle cell disease and CF. How can we best share best practices to educate staff to enhance student achievement? And Mary Houlihan from CDC just attended a call at the American Society of Hematology this morning. So this is hot off the press. They're developing an online binder of information to assist staff for students with sickle cell and anticipate the release sometime later this year or in the next school year, in time for the next school year. So I don't know if Amy or Stacey, you have other thoughts on how we can best educate staff to enhance student achievement.
Yeah, I think so for sickle cell disease, and thank you, Chris. Chris is actually one of our school teachers here at Children's Healthcare of Atlanta. For sickle cell disease, I think one of the biggest challenges is just awareness of the disease. So the more community engagement and community education we can provide, I think the better overall for our patients. I know we have one at least very active parent-led community group who, the parent has 3 children with sickle cell disease, and she goes to their individual schools and talks to their teachers about the disease and what all they need. But a lot of parents don't have the time or the resources to do this. And I think engaging with our community-based advocacy groups is really important in that arena.
Yeah, I agree. I think at least around here, we all try to get in line to talk about our system or our disease or syndrome with the medical school. But I think as much engagement as us in academic facilities as possible is great. Engaging community members but also patients and families. I know that most of my memorable lectures and things involved connection with someone, a family or a patient. So I think continuing to partner with the schools and bringing in really real world examples, I think is a way to have lasting impressions on students, but you have to make those connections first.
And I guess one of my questions then for both of you and for others, maybe even at the federal level on the call, are there efforts to bring groups together so that when you want to go to a school system and you can have the sickle cell and the CF docs talking at the same time to kind of maximize your message and your time in front of those partners?
Yeah, I think that's a great thought. There's certainly a lot of diseases out there where there's just a lack of awareness and education. And so I think it would be great if we could organize some sort of forum where the medical groups could come to the different schools in the area, talk to the teachers, but also to the students about the disease. Because, for sickle cell disease, and I'm sure for CF also, most of these patients don't look like they're somebody that's sick, So a lot of patients are able to, appear as somebody that feels well and doesn't have any issues, but they're actually dealing with a lot of internal issues that they're not necessarily sharing with their friends or their peers.
Yeah, perfect. And I'm hoping everyone's following the chat. We've had Marissa Rollins from the CF Foundation has posted some information for talking to teachers in schools in the chat, and Mary Houlihan from CDC also posted something from CHOP in the chat. So this is fantastic. Lots of resources are being shared. So I am going to say, is there a national database that tracks the CF false negatives? I'm going to go ahead and answer this because I think there potentially are two, and I'm not sure we do a fantastic job either place of doing it. I think New Steps tries to collect that. That's a HRSA-funded program at the Association for Public Health Laboratories. That is the Newborn Screening Technical Assistance Center that tries to collect false negatives. And the other place is through the CF Foundation and their patient registry. And through that patient registry, as you enter information about a given infant, you can check, yes, this is a false negative on newborn screening. I think both of them are challenged by getting that accurate information. So I'm not sure, Kate, if we have a good national number on false negatives. And in addition to that, as you very well know, Kate, from who runs the Delaware Newborn Screening Program, the state newborn screening program should also be doing that. So I'm so sorry to have to do this because I could just stay and talk with all of you for the next 2 hours, but we have reached the end of our time. So thank you so very much for joining us today for this webinar. We very much appreciate your participation. And I'd like to thank Dr. Martiniano and Dr. Tang for presenting for us, and Megan Lyon for helping us to organize this in collaboration with the CF Foundation. So thank you so much and enjoy your afternoon. And we hope you tune in for other Public Health Genetics Week activities.